Okay. The next candidate. Ready?
Assalamualaikum, sir.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
I'm good. How are you?
Okay, let's start with an easy case. Ask for control.
Sir, I'm
Okay. Yes, I'll give you this one. Yeah, start.
okay.
Acute abdomen.
Sir, any history? Okay.
Okay.
So, this is city abdomen. This is no, non-contrast image.
Actually, it's a delayed
Oral
phase.
count.
Okay. Okay.
Okay.
Delayed portal.
All
Okay.
right. So I will first scroll from top to bottom, and then I'll start commenting. A patient has presented with acute abdomen. Yeah. So the obvious abnormality that I can appreciate is there is in the right iliac fossa. Uh, okay, now I'm trying to look. There is a peripherally enhancing collection is seen in the subhepatic location, and the subhepatic location, and uh, it's not scrolling. Okay, it's scrolling, but it's taking a bit time.
Show me,
Now I'm trying to look for.
show me this collection.
So this area. Can you see my mouse?
Go up, go up, go up, go up, 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 up.
Okay. So this.
This one. So
Yes,
this
sir.
one, where is the cecum?
Okay.
Yes,
Okay. So this
this
is
area.
cecum
This,
basically.
yes. Okay, so the large collection is the cecum actually, and below it,
Okay.
starting smudging of
It's
the fat
just
planes
fatty.
and air fluid level.
Yeah, I can also see an appendicular, and
Yes,
within
very
it,
good.
and there is a heterogeneously enhance heterogeneously enhancing area with there are I can also appreciate few air locules within it. In the region of the iliac fossa, I cannot
Excellent.
appreciate the appendix separately.
Any lymph nodes?
Yeah, I'm looking for now. I'm looking for the lymph nodes. I can find few
Multiple. Yes.
multiple adjacent lymph nodes.
Very good.
As patient is presenting with acute abdomen, this is likely a case of appendicular abscess
Good.
and with phlegmon formation. Because I cannot appreciate the appendix separately. Mild associated thickening of the cecum is also seen.
Reactive. Yes.
Yeah, which is reactive. I would also like to see the lung window to look for pneumoperitoneum.
Excellent. Important point. Very good.
Yeah. Uh,
What
so I
else
think uh,
you should comment
other than
on?
that, uh, sir, pneumoperitoneum, fat straining,
Other
and
complications, like what?
yeah, other like thrombosis, vascular
Yes,
thrombosis.
yes, very good. Like any inflammatory condition or infectious condition, it can lead to thrombosis. So any abdominal
Thrombosis.
thrombosis, and this like a diverticular disease, the final drainage into mesenteric and portal into the liver. So I have to rule out the
Okay,
presence
all
of.
right. Yeah, I would also like to see the liver to look for any hepatic abscess, which I
Very good,
cannot find.
very good, very good. So
So
final diagnosis
yeah.
and management.
So yeah. So this is a case of the appendicular abscess, and I would immediately inform the referring physician of the findings, and this patient needs urgent surgical intervention.
So the expected management is appendectomy.
Sir, I think it would be first treated medically and then
Abscess.
uh,
Medically?
okay,
No.
sorry. Okay. Interventional radiology role,
Yes.
and it will be
Drainage.
drained.
Yes, drainage,
Yeah,
then
it will
elective
be
appendectomy. Okay,
elective.
very good as a start. I'll give you another case, but just to revise, this is a very common condition, my friends, not just for the exam, but it's extremely common in practice. So any radiology residents see this يعني, session, please revise as much as you can from this type of cases. Ignore this one. It's not enhancing. Can you just give me the mouse? Give me the mouse. Yes,
Okay,
I
sir.
will scroll. This is an easy case. Okay, just
Okay,
straight
sir.
forward. You see another case of acute abdomen. This is a clue. Concentrate on this one. I know we have a tubular structure, okay, and it contains
The
hyperdense.
appendicular.
Yes. In the exam, most likely it's appendix. But take care. Here it's arising from a normal location. Sometimes it's higher. Also appendix. What if
Subhepatic.
yes, subhepatic. What if arising from small bowel? Oh, it's different. It will be
Yeah. Mickel's diverticulum.
yes, if a tubular structure with a feculus or appendiculus-like structure arising from small bowel, it will be Meckel's diverticulum. What if similar tubular structure arising from the left side and I cannot see the cecum? Instead, the cecum will be
It
here.
would be non-rotation. It would be
Excellent.
non-rotation with
Excellent.
appendicitis.
Very good. Very good. It will be a non-rotation or malrotation. This is a clue. Okay, the appendiculus is a clue. So regarding your case, I have a collection, whether enhancing wall collection or air fluid inside. The presence of hyperdense structure is the clue. Even in the right iliac fossa, in the subhepatic location, this means appendiculus. Okay, so it's appendiceal abscess. If appendicitis, urgent appendectomy. If appendiceal abscess, drainage. If phlegmon, okay, phlegmon may be conservative medical, okay, if no abscess formation, just inflamed fat around. Then elective appendectomy. Okay, my friend, I'll give you
Sir,
another.
sir, I have, sir, I want to ask one question. Sir, how to differentiate between phlegmon, how it would be presented? Like,
Excessive smudging of the fat planes. It
can we
simulate
see appendix separately in phlegmon?
sometimes no, sometimes no. But take care. If you see appendiculus outside, it means rupture. It means rupture. So appendiculus is very important to judge the next step. Appendiculus is a leading clue. Okay, acute abdomen.
Thank you, sir.
Proceed.
So this is a city abdomen. This is non-contrast image.
Yes, correct
I
this
will
time.
I will okay, yeah, I have seen the abnormality, but I would like to see from top to bottom, and then I'll start commenting. In my normal practice, I go till the last cut to do not miss any pathology. The obvious abnormality that I can appreciate in this scan is there is
Use
an
your mouse.
appendiculate.
Use the
Okay,
mouse.
there is an appendix. Okay, sir. Yeah,
Yes.
there's an appendiculate in the subhepatic location,
There is the
which is
appendix. Yes.
likely in the
Good.
yeah,
Good.
appendix is seen in the subhepatic location with appendiculate. There is a appendix is also mildly dilated with adjacent fat stranding.
Is it mildly dilated? And is there any fat stranding? Honestly, no significant fat
Sir,
stranding. So
sir,
the clinician
yeah,
and where is the appendiculate? It's at the base
sir,
or the tip?
at the base, yeah,
At the
Sir,
base?
it is at
Are
the
you sure?
tip. At the tip.
At the yes, at the tip. Okay, so the clinician
Yes.
chose to follow up this case. I'll give you the follow-up now. But first, just to show you, my friends, you see, normal sized appendix. And by the way, the presence of air inside the appendix is
Yes.
a good sign. This is a good sign. It means patent
Yes.
lumen.
Yes.
And the presence of appendiculus, it's not at the base. If present at the base, definitely it will go into appendicitis. But this is a deceiving condition in practice. Why? Because we have a condition called tip appendicitis. Even if a few millimeter of the appendix remaining, it will be inflamed. Okay, let's see. Yes, this case, I think after a couple of days on follow-up, the patient deteriorated. You can scroll.
Yes. So this is the CT scan of the same patient after a few days. Now I can appreciate there is a mild right-sided pleural effusion. There is a large hepatic collection, a subhepatic collection is seen in the previously seen location of the appendiculate. I can also see appendiculate within it. Few air locules are seen. Now appendix is also appear inflamed, thickened, with the fat stranding also seen involving the cecum. So now findings are likely suggestive of appendicitis with subhepatic abscess formation.
Yes, it's ruptured tip appendicitis with
Yeah.
perihepatic or
Yeah.
subhepatic abscess formation.
Abscess,
And
yeah.
again, the drainage will be the optimum pathway. So surgical and intervention radiology
Interventional.
team. Drainage of abscess together with the medication and elective appendectomy. Very good, my friend. Again, no, I will judge on the this is, of course, porto venous, no venous thrombosis, no hepatic abscess
No
formation, the
hepatic
rest of
abscess.
complication. And also look at the lung window. Very good, my friend. Very good. Very good. I'll take the mouse now. The next candidate. You see, my friends, here, this is the rest again of the appendix. Still here. So it's a case of complicated tip appendicitis. Any other candidate ready?
Yes, I'm ready, doctor.
Okay, boss. I think this is another easy case to start.
Okay. I request a control.
You have it.
Okay,
Acute
thank you.
abdomen.
Okay, I'm presented with the CT abdomen with the contrast in the portovenous phase for the patient with the acute abdomen. I scroll through the study before I start commenting. I can see that there is motion artifact.
Okay.
I can see like a thrombosed blood vessel here.
Very good. Very good. Name
Um,
this blood vessel.
I think it's ovarian
Yes, it's
vein.
right ovarian vein. Yes, right ovarian vein, thrombophlebitis.
Yeah.
Very good, my friend. I'll give a comment later. What else?
Okay. I can see that there is at the right iliac fossa there is fat stranding and minimal fluid collection and thickening of the peritoneum.
So if you see smudging of the fat plane at the right iliac fossa, what you should look for?
Yeah, I'm looking for the appendix.
Do you see any clue like appendicular? Actually, no.
No, I can't see
Any other clue like tubular structure?
Yes, maybe I'm suspecting this one.
Yes. a tubular fluid filled, but it's convoluted upon itself. So
Yeah.
you may ask for another planes.
Yeah.
For
Yeah,
example, if
check the
a
Crohn.
coronal or a sagittal plane, you see this tubular structure now, ring
Yes.
enhancing tubular structure arising from or close to the area of the cecum. You see,
Cecum, yeah.
its base, yes, at the close to the ileocecal junction. Okay.
Yes.
So
Preparation
diagnosis in
for
such case.
appendicitis. Yeah, acute appendicitis complicated with the ovarian vein thrombophlebitis.
Very good, very good. It's complicated with ovarian vein thrombophlebitis. You see, my friends, this is a right ovarian vein. Right ovarian vein drains into the IVC directly, but the left ovarian vein drains into the left renal vein. Very good. Again, it's a surgical case. Okay. Just revise the anatomy. This is the psoas. Two structures runs anterior to the psoas. Bismillah ar-Rahman. The ureter and ovarian vein. So ovarian vein on each side, or we can call it gonadal vein because in male gonadal or testicular. And here it joins the IVC at about 10 o'clock. Okay, down, down, down. Very good, my friend. We have a filling effect and the smudging fat planes around. Okay, unlike this one, left ovarian vein, which is normal caliber. Away from this case, in a patient with vaginal bleeding and unexplained, we should assess, or chronic pelvic pain, we should assess the left ovarian vein, commonly enlarge it and show reflux. Okay, back again to this thrombosed vein. What is the commonest cause for ovarian vein thrombophlebitis? Is it appendicitis?
No, I think that it's a BID and tube ovarian.
Yes, very good. BID. So another possible diagnosis, if I told you the patient has appendectomy before, it may be a tube ovarian abscess, maybe biosalpinx. Okay?
Yes.
Especially if postpartum period or post-cesarean period, and you see here some air locules in the uterus. Okay, and if this is the only pathology, then thrombolytic therapy, not surgery. Very good, my friend. So again, I'll give you another case. Let's revise complications. Diverticulitis, appendicitis, pancreatitis. You should assess for venous thrombosis. It's a known and unfortunately commonly missed complication. Okay, I'll give you another not easy case. Okay, acute abdomen.
Lucky me.
No, it's easy. Okay, you can proceed.
Okay. I'm presented with TT abdomen with contrast in the portovenous phase. Just scroll down the study. I can see that there is right inguinal hernia.
Very good. Right inguinal hernia type.
With the
direct or indirect?
Just a second. It's indirect.
Definitely indirect. It runs along the spermatic cord. Okay.
Yes, it's indirect.
And any other clue?
It contains the fat and
I'm sorry. Any other clue to differentiate direct from indirect?
the inferior epigastric vessels.
Yes. Okay.
Yeah.
Good. In case of indirect, it will be medial or lateral?
Lateral.
Okay, good.
Okay.
What do you see in this hernia?
It contains just fat, omental fat fluid.
Good.
And it shows and a lymph node, enlarged lymph node, and I can see surrounding stranding and thickening that would be suspicious for either infection or strangulation.
So, يعني strangulated what? Fat or bowel? within this hernia? Go down for the hernia. Go down. Go down.
Yes.
What about this? Okay, let me help. I will take the control. Okay. I told you it's a difficult. Okay.
Okay.
What about this calcific focus?
Application, yeah.
And what about this rounded structure? Rounded, up, connected to the base of the cecum.
Yeah.
You see this area? This one, this one, this one, this one, this one, this one. Okay, then calcific focus. So what happened?
The appendix herniated.
Yes, yes. Herniated appendix and ruptured. It's called amnion hernia. Complicated hernia containing appendix is called amnion hernia. And here it is ruptured, okay, perforated. So complicated by perforated appendicitis. It's urgent surgical condition. I'll give you another case because this is a difficult one.
Okay.
Okay, no problem. No, we are learning together. It's okay. Okay. No, this one will be difficult. This one easy. Okay. Okay, my friend. I'll ask for control again. This is an easy case. And I want a classic approach. Acute abdomen, 25 years old.
Okay. I'm presented with CT abdomen contrast in arterial phase. Just to scan through the study. You cannot see abnormality in the liver. Kidneys looks fine.
Avoid in the exam, my friends, avoid long stop. Okay, either you scroll rapidly, or if you see multiple cuts like here, avoid long stop. I don't see any ring enhancing lesion or margin enhancing lesion in the liver. Normal fat planes around the pancreas, normal fat planes around the kidneys. Okay, I am going down to the bowel. Okay, just talk. Continue talking. Okay. What do you see
I can
here?
see that the terminal ileum is thickened with hyper-enhancing mucosa with a comp sign with increase in the vasculature to the terminal ileum.
It's
I'm looking for the rest
case.
of the bowel to check if there is other lesions. I can appreciate that the colon as well as the sigmoid colon may have another area. These findings it's surrounding fast stranding and minimal fluid. It's my primary diagnosis will be Crohn's disease.
Okay.
I'll check if there is any fistulous tracts or abscess formation. I would like to turn to the
also
well.
mention normal
No
appendix.
obstruction.
Show me the appendix. It's very important.
Yeah. It is not scrolling.
Show me. No, you should look for appendix. Up.
Yeah,
Yes,
scrolling
here.
stopped.
Yes. You see the appendix now? It's retrocecal in this case. You see it? Far posterior.
Okay, it's
where?
It's me scrolling.
I will scroll.
The
I will scroll. I will scroll. No, leave the mouse.
This is the appendix, yeah.
Yes, I leave the mouse. I will help in scrolling.
This is the appendix, yeah.
This is the appendix, okay,
Yeah.
in a retrocecal location, okay. I have internet problem.
Yeah, it's a bit, there is lag, yeah.
No, it showed me some internet problem on my side. No problem.
Okay.
So normal appendix, thickened, hyper-enhancing terminal ileum, smudging fat planes, and engorged vessels. It's comb sign. I'm looking upward, no other area of inflammation, so no multifocality or skip lesions should be mentioned. What else you should mention?
Fistulous formation, abscess. formation,
or perforation. So
perforation, obstruction, stricture formation, and obstruction, small bowel
excellent.
obstruction.
And
And less likely associated sacroiliitis, gallbladder stones, complications, which is less likely to be malignancy.
gallstones, venous thrombosis, liver abscess. Very good. And lung window for any perforation. Bone window.
Yeah. Bone window for sacroiliitis.
Yes, very good. Bone window for sacroiliitis and also for any complication of therapy.
At the end, due to steroids.
Very good, my friend. So the diagnosis in this case and management?
I will confine the findings to the referring physician in for medical therapy and follow-up.
Okay. How to follow up this case?
I think MR interrography
Excellent,
to
excellent, very good. Any
check for
specific
activity.
laboratory test for Crohn's disease?
I'm not sure.
No problem.
No,
Anyone know? It's okay.
inflammatory markers, maybe. I don't know.
Inflammatory markers, general, good. What else? Yes, the complication on bone window is the AVN because of steroids. And the laboratory test, fecal calprotectin. Fecal calprotectin. Thank you, Dr. Amir. Thank you. Thank you, my friend. Thank you.
Thank you so much, Doctor.
Welcome. I think we have one candidate remaining, Dr. Amiga, correct?
Yes, sir. We have one. So, seventh candidate.
Okay. Ready? The next candidate ready or?
Candidate 7.
Yes.
Okay. Can you raise your voice, please?
Yeah, sure. Sorry. Yeah.
Yes. How are you, my friend?
Yeah, I'm fine. Thank you.
Okay. I'll give you. Yes.
Okay, so I'm presented with an AP view of.
Yes.
Yeah. So I'm presented with an AB view of an abdominal X-ray. The striking abnormality is multiple air fluid levels in the center of the abdomen with the string beaded signs suggesting intestinal obstruction. It is in the center of the abdomen with no history seen, so it suggests small bowel obstruction.
Very good.
So on this plain X-ray, I should also exclude if there are any signs of pneumoperitoneum due to perforation of the obstructed segment. However, I cannot see. I cannot see the upper border of the diaphragm, so I cannot really appreciate any pneumoperitoneum.
So I suggest another radiograph for the upper abdomen or lower chest. Very good, my friend. Like this one. They asked it already for it. Very good. This is important. Okay,
I still cannot see any pneumoperitoneum, so my next step will be asking for CT abdomen with contrast to search for the cause of obstruction. And also on the plain X-ray, if it was apparent, the foraminal orifice,
yes, important. I don't see the groin. Maybe just hernia.
Okay. And it's not seen on this X-ray. However, my next step after checking the upper abdomen and the lower and the groin would be CT with IV to search for the possible cause of this obstruction.
Okay, so no possible causes can be detected from the radiograph, like surgical clips, like radio opaque shadow, like many causes can be detected in radiograph. You should mention what are the causes of small bowel obstruction, my friend?
Yeah, the most common cause is adhesive bands that can be follow any post surgery. So I should be looking for clips.
Good.
I cannot
what else?
See clips. Also, gallbladder ileus. I'll see like pneumobilia and the
Very good.
gallstone. However, I cannot really appreciate any pneumobilia.
Very good. So we comment on the liver, any branching lucency. Also, it may be secondary to ischemic bowel. Again, no portal venous gas, no branching lucency overlying the liver. So we comment on the liver, any branching lucency. It could be pneumobilia, could be portal venous gas. Surgical clips, radio opaque shadow, as in gallstone ileus, and others. I'll give you a CT scan because others present already in the radiograph, but we will cover it later on. You
Okay.
can proceed.
Okay, 1 second. Yeah, I'm scrolling now. I'm given a post-contrast CT abdomen, venous post-contrast venous phase. I'm scrolling down now, looking for the cause of the obstruction seen on the previous radiograph. I see the liver, the kidneys are normal. No, I have not seen neoperitoneum. However, I'll still see the lung window to check again. However, the striking abnormality is this focus of this is small, but 1 second, I'm just scrolling to determine the bowel.
Yes. Scroll till the end. It's
Yeah,
important step.
yeah. So
Till the last cut.
it's
Till the last cut. Otherwise,
okay.
you will lose marks because
Yeah,
FRCR exam is called film edge finding. Okay.
yeah. So there is intra-abdominal collection. The bowel seems to be the dilated or thickened bowel loop seems to be ileal bowel loop,
Good.
mid to
Show
terminal
me
ileal bowel
where.
loop. Yeah, it is here.
Yes, very
I
good.
mean, the transition somehow is here. The transition showed like thickened. The wall is thickened.
Good.
Okay.
What about other findings?
Yeah. There is related collection to this bowel. I'm just still tracing.
Collection or reactive fluid around?
Yeah. Reactive fluid. Yeah.
Yes, because
Uh,
collection means abscess, for example. Okay, good.
y-
So we have a segment of the ileum showing mural thickening and hyper or hypo enhancement.
I'm just trying to determine the proximal and the distal ends of the bowel. Okay. To 1 second, please. I'm sorry. 1 second.
Take your time. Take your time.
Yeah, thank you. So it is here. This is the distal, and then it is collapsed with thickened appearance of the wall, and then it is dilated here. Okay, and then
I
I'm
don't
sorry.
know
I'm
what
sorry.
you did.
I
No
didn't. I
problem.
didn't. I didn't. I
Okay.
didn't read. Anyways, I didn't read it. I'm sorry.
Okay.
I pressed on the wrong arrow.
Okay.
So, and this here it goes up, and it is dilated. So it is. I'm sorry
You
again. I
you
still read
need
it.
to okay. This is a sheet.
I didn't
Okay.
read, I swear.
No
Anyways,
problem.
so it is a terminal to mid-ileal bowel loop that show bowel wall thickening with dilatation. The second thing I should comment on is the enhancement of
Yes.
the wall.
If hyper enhancement, it's inflammatory. If hypo enhancement, it's ischemia, and I
Yeah.
should comment on the vessels. It's very
Uh,
important.
Yes. However, it doesn't. I mean, this segment, the dilated segment here, it doesn't really seem either hypo or it's not hyper enhancing.
You did a mistake here. How
I
many times you go up and down in this study?
a lot.
So many times.
Yeah.
Many times. Okay. In the exam, 1 or 2 maximum.
Okay.
Okay. Because
Okay.
now you lose concentration. You detected an abnormality, which is bowel. Very good. Is it focal segment or multiple segment? You should mention this point. Is it hyper enhancing or hypo enhancing? What are stop, my friend. Okay,
I'm
stop.
sorry. I'm sorry. Yeah,
No
I'm
need,
sorry.
no need for go up and down. Go up, you will lose marks, by the way. Yani, okay.
Yeah. Okay.
So take care of. I will take control now. Okay.
Okay. So
I'll guide you. So you detected an area of mural thickening, collapsed the bowel, followed by a proximal obstruction and dilatation of the proximal upstream. So
Yeah.
this is the transition point, which is inflammatory, no mass.
Yeah.
Okay, it's hyper enhancing and
there is a comb.
yes.
Yeah, there is a comb sign. Yeah.
Yes.
So
There is
yeah.
a comb sign sometimes associated with a few small lymphadenopathy. No other areas of a similar mural thickening. Okay, I'll comment on the vessels. I'll comment on the liver, no gallbladder, no stones, and. So it looks like an area of stricture of the terminal ileum with terminal ileitis. Okay,
Yes.
what else you should look for? The same.
So in the dilated bowel loop, I want to exclude any extra luminal gas.
Good.
I'm suspecting a focus of air here. I just want to check if it is inside the bowel or outside.
Okay, by the way, some lymphadenopathy. Good. So I want to check lung window.
Maybe,
What
yeah,
else?
lung window and other planes to see if this focus of air is inside or outside of the bowel.
Good.
The enhancement of the dilated bowel loop, it seems
Mm.
no, I don't, maybe hypo-enhancing to normal. However, it
No.
does
It's a hyper. With
this.
engorged vessels, yes,
No,
it's
no, I
hyper.
don't mean, I mean the dilated segment. I mean the dilated segment, not
No,
the,
just mural, okay, thickening, no
yeah, yeah.
problem.
So
It's
yeah,
enhancing.
something
It's
called the,
normally
yeah.
enhancing.
Yeah. So, and this is, yeah, hyper enhancing. So, a terminal ileum, terminal ileitis hyper enhancement with bowel thickening and related comb sign with proximal dilatation. So, I may also be thinking of Crohn's
Good.
disease. If
Complicated
this
by
is,
stricture and low-grade bowel obstruction. Very good. What else?
yeah, with activity now because of the hyper enhancement and the comb sign. If this is Crohn's disease, I'd like to exclude the other association like other strictures, skip lesions. I'm sorry, skip.
Good. No other
I should
focality
not,
or skip lesions. Good.
yeah, and I should examine other organs. And also, I talked about the pneumoperitoneum, and I should also examine other organs for any association. The previously mentioned gallbladder stones, the perianal fistulas, sometimes the autoimmune cholangitis, and also the bone for the sacroiliitis. And then
Yes, it's present here.
yeah, it is
I am
present.
waiting.
Yeah,
Okay.
yeah. So I want to see the bone window. It
Okay.
seems to be like.
You see it from this window?
Here, there seems to be a bit of fusion, yeah, but it will be apparent more on the bone.
Comparison.
Yeah.
Good. It's you should detect even minimal changes in the soft tissue window. Then
Yeah.
ask for bone window.
Yeah.
Okay.
It's
And
supposed to
here,
be bilateral symmetrical.
yes, it's
But this is not
yes.
symmetrical.
I
Yeah.
agree. It should be symmetrical. Here is symmetrical, but definitely it's a sign.
Yeah,
Okay.
sure. Yeah.
Very good. Back to the plain radiograph now. You see some bamboo spine and some sacroiliitis. It's another finding in case of small bowel obstruction.
Yeah.
If you see a small bowel obstruction, comment on the presence or absence, surgical clips, radiopaque shadow, hernial orifices, linear lucency, overlying. So many causes can be detected on the plain radiograph. Very good, my friend. Now to the last case. This is just an easy case. Give me the diagnosis, just diagnosis. Okay.
Yeah, acute cholecystitis.
It's acute cholecystitis, hyper enhancing, thickened wall, smudging of the fat planes, expanded. This is important, expanded, and we have one or more stones at its neck. Reactive thickening of the CBD can be seen. So reactive cholangitis, it's mild form. By the way, in case of pancreatitis, reactive thickening and enhancement can be seen also. You remember this case of Dr. Amiga? It's reactive thickening and enhancement. Okay? The next case is the last one.
Okay.
I'll give you control again. Ask for control. Is the last case.
Okay.
So the previous case, classic acute calcular cholecystitis.
Yeah, okay.
Right upper quadrant pain.
Okay, so I'm given a post-contrast CT of a patient complaining of right upper quadrant pain. I'm examining the axial slices from up downwards. Okay, there is a left renal cyst. The gallbladder seems to be massively distended.
Good.
However, I cannot really appreciate significant wall edema. There is related collection to the gallbladder at the gallbladder bed, and it is distended. Okay, so there is no, I'm still examining the liver because there is no aerobilia or anything.
Good. So the diagnosis in this case is simply cholecystitis, acute cholecystitis. I don't see definitive.
I cannot see a gallbladder stone, so it is
Radiodensity stone. Good.
radiodens. Yeah, it may be a calcular cholecystitis. I was scrolling to, I'm sorry, I'm scrolling up and down again, but I was scrolling to exclude.
Yes. Please concentrate. Avoid long stop and avoid scrolling up and down. Okay.
Yeah, because I was thinking about excluding the complications, but again, it is distended. The complication may be like fistula or perforation. However,
Good.
it has been not distended, so they are probably not there, and that's what I was. That's why I was scrolling up and
Okay.
down.
Follow up of this case 2 days later.
Okay. Okay, so the collection apparently increased, the
Good.
perihepatic collection increased, the gallbladder is still distended. However, I cannot see enhancement of the wall in the
Excellent.
previous. So
That's it.
this denotes gangrenous cholecystitis,
Excellent.
still
Okay.
not collapse, so maybe with impending perforation and increase in the the fast stranding and the subhepatic and perihepatic collection and fast stranding. So this is
Very
an
good.
emergency, and I should convey this to the clinician for the clinician and surgeon and the interventional radiology to insert maybe a tube to
If
do
the patient is operable, okay, or surgically fit, cholecystectomy can be done. If
Okay.
old age and unfit, cholecystostomy.
Yeah,
Then
I mean,
intervention radiology. You mean this one, okay?
yeah.
Very good, my friends. So on the first study, you see, my friends, enhancing wall. By the way, it's common to see a stone on ultrasound. On case of CT scans, the stone may be radiolucent. It's not radio opaque, but commonly a stone should be seen. You see here from the first study some debris inside. You see this?
Yes.
It may be slaved mucosa, maybe
Yeah.
slaved wall. Okay. On the second study, lack of wall enhancement. It's gangrenous. It's definitely gangrenous, but still not perforated yet since it is distended. Excellent, my friend. Excellent. Thank you.
Thank you. Thank you.
Okay, well done, my friends. This is the second session in GI. What I'm telling you in this session, please revise acute inflammations within the abdomen. In the last session, IO, and we should look for a cause and approach. Is it small bowel? Is it large bowel? What are the possible causes? And what's the next step? Today, some of the acute inflammatory causes, whether affecting the bowel itself, as in case of appendicitis, ileitis, diverticulitis, or other organs like cholecystitis, like pancreatitis, hepatic abscess, and so on. So please try to see as many as you can regarding the complications. Thank you, my friends. Inshallah, in the next session, I'll try to cover GU emergencies. See you next Saturday.